is Palacio, and for this video, I'm going to tackle about toxicology or in how to manage if you are being poisoned of toxic substances. So let's start with defining what is poisoning. So poisoning is defined as a pathologic state caused by a toxic agent. Sources of poisoning include medications, plants, environmental pollutants, and drugs of abuse. These toxicants may enter the body orally or by injection, inhalation, or absorption through the skin. So poisoning may be unintentional or accidental or intentional. And symptoms of poisoning often mimic those of disease. And hence the possibility of poisoning should be considered whenever a diagnosis is made. So poisoning is a medical emergency and requires rapid treatment. So fundamentals of treatment of poisoning has 5 components. So these are the supportive care, poison identification, prevention of further absorption, poison removal, and use of specific antidotes. So let's tackle each. So first is the supportive care. So supportive care is the most important element in managing acute poisoning. So support is based on the clinical status and requires no knowledge specific to the poison involved. So maintenance of respiration and circulation are primary concerns. Then measures for respiratory support include inserting an airway, giving humidified oxygen, and providing mechanical ventilation. Then volume depletion resulting from vomiting, diarrhea, or sweating can compromise circulation. Then severe hypoglycemia may occur resulting in coma. So levels of blood glucose should be monitored. So for coma of unknown etiology, IV dextrose should be given immediately even if information in blood glucose is lacking. Then acid-base disturbances may occur, so determination of arterial blood gases will facilitate diagnosis and management. If seizures develop, IV benzodiazepines are the treatment of choice. Then the second one is the poison identification. So treatment of poisoning is facilitated by knowing the identity and dosage of the toxicant. So efforts to obtain this information should proceed concurrently with medical management. A history is one way to identify the toxic agent. However, experience has shown that histories taken at times of poisoning are often inaccurate. Hence, statements about the nature or quantity of poison may be incorrect. But positive identification can be made by using analytic techniques. For example, a gas chromatograph or mass spectrometer can provide qualitative and quantitative information. So, analysis can be performed on specimens of urine, blood, and gastric contacts. So, to determine whether poison levels are rising or falling, analysis should be performed on sequential blood samples taken about 2 hours apart. Then the third one is the prevention of further absorption. So by reducing the absorption of a poison, we can minimize blood levels and thereby significantly decrease morbidity and mortality. So for ingested poisons, 3 procedures are available. So the first one is giving activated charcoal. Second one is gastric lavage and aspiration. Then the third one is the whole bowel irrigation. But when poison exposure is topical, surface decontamination is employed. So these 3 procedures will be discussed further later. So next is the promotion of poison removal. So measures that help eliminate poison from the body, shorten the duration of exposure, and if implemented before plasma levels have peaked, it can reduce the maximum level of poisoning achieved. So by shortening exposure and reducing maximum poison levels, these measures can decrease morbidity and mortality. Then removal of poison can be promoted with drugs and non-pharmacologic techniques. The drugs used for poison removal act by increasing renal excretion of toxic agents. Then non-pharmacologic methods of poison removal include hemodialysis and exchange transfusion. So details on methods of poison removal are presented later. Then the last component is the use of specific antidotes. An antidote is an agent administered to counteract the effects of a poison. So examples include naloxone to reverse poisoning by heroin and other opioids. And the other one is the physostigmine to treat poisoning by atropine and other anticholinergic drugs. So several specific antidotes are discussed later. Unfortunately, although antidotes can be extremely valuable, these agents are rare. So for most poisons, no specific antidote exists. Hence, for most patients, treatment is limited to the general measures just described. Drugs and procedures used to minimize poison absorption. So we have two. First is the reducing absorption of ingested poison. So under that are activated charcoal, gastric lavage and aspiration, and whole bowel irrigation. Then the other one is the surface decontamination. So let's discuss first the reducing absorption of ingested poisons. So first, the activated charcoal. So treatment with activated charcoal is a preferred method for removing ingested poisons from the GI tract. Activated charcoal is an inert substance that absorbs drugs and other chemicals. So binding of toxicants to charcoal is essentially irreversible because charcoal particles cannot be absorbed into the blood, so absorption of poisons into charcoal prevents toxicity. Then the charcoal poison complex is eliminated in the stool, so patients should be advised that charcoal will turn the feces black. Charcoal is very safe but should not be used in patients with bowel perforation or obstruction. Charcoal selectivity absorbs large molecules that contain a carbon atom. So absorption of small molecules and molecules that lack a carbon atom is poor. So among these poorly absorbed molecules are heavy metals, caustics and corrosives, alcohols and glycols, chlorine, iodine, and petroleum distillates. So because charcoal can absorb antidotes and thereby neutralize their benefits. So antidotes should not be administered immediately before, with, or shortly after the charcoal. So activated charcoal has the consistency of a fine powder and is mixed with water for oral administration. So the adult dose is 25 to 100 grams. Then pediatric doses range from 25 to 50 grams. For poisoning with certain compounds such as phenobarbital, dapsone, quinine, theophylline, and carbamazepam, giving sequential doses of charcoal can be beneficial. So when administered within 30 minutes after poison ingestion, charcoal can absorb about 90% of the dose. However, if given 60 minutes after poison ingestion, the amount absorbed decreases to only 37%. So clearly, charcoal should be given as soon as possible after poison exposure. Gastric lavage and aspiration. So gastric lavage or irrigation and aspiration consist of flushing the stomach with fluid and then sucking or aspirating the fluid back out. So the procedure should be done only in life-threatening cases and only if less than 1 hour has elapsed since poison ingestion or exposure. Lavage and aspiration are accomplished by using a large bore orogastric tube, number 36 to 42 French for adults, then number 22 to 28 French for children. So smaller tubes should be avoided because they may not permit the removal of solids such as food, pills, capsules, or tablets. And because their small diameter would impede the flow of the lavage fluid. So if the patient is comatose, an endotracheal tube with an inflatable cuff should be installed to protect the airway. Because of the anatomy of the stomach, the patient should be placed on the left side with the head down. Prior to initiation of lavage, stomach contents should be aspirated and sent for toxicologic analysis. So lavage may be performed with tap water or saline solution. So multiple washes are instilled using 150 to 200 ml per wash for adults and older children, or 50 to 100 ml per wash for children under 5 years old. So larger volumes should be avoided since they may push stomach contents into the small intestine. Then washes should be repeated until the fluid retrieved from stomach is clear. So it is about 10 to 12 washes are employed. In addition, specific contraindications to lavage and aspiration include the following. So first, unprotected airway. Second is the caustic ingestion due to risk of exacerbating any esophageal or gastric injury or coagulopathy. Whole bowel irrigation. Whole bowel irrigation is done with a solution of polyethylene glycol that contains balanced electrolytes. So available under the brand names Colite and Go Lightly. So the solution is administered repeatedly over a 5-hour period, either by mouth or through nasogastric tube. So rates of administration are as follows. So for patients aged 12 years and older, that is 1.5 to 2 liters per hour. Then for patients 6 to 12 years old, 1 liter per hour. Then for patients younger than 6 years old, 0.5 liters per hour. So the procedure has been effective following the ingestion of iron, lithium, and lead, as well as sustained release products. So whole bowel irrigation should not be used in patients with ileus, peritonitis, bloody vomitus, or obstruction or perforation of the bowel. Surface decontamination. So topical exposure to toxicants can cause local and systemic injury. So to minimize injury, contaminated clothing should be removed and the poison should be washed from the victim. So the recommended procedure is to alternate soap and water washes with alcohol washes. So personnel performing these washes should take precautions to avoid contaminating themselves. So if the victim's eyes have been exposed, they should be flushed with water for at least 15 minutes. Then shampoo should be used to remove toxic agents from the hair and scalp. Now let's discuss the drugs and procedures used for poison removal. So first, the drugs that enhance renal excretion, and the other one is the non-drug methods of poison removal. So first, for the drugs that enhance renal excretion, so drugs that alter the pH of urine can accelerate the excretion of organic acids and bases. So agents that elevate urinary pH, such for example, make the urine more alkaline, so it will promote the excretion of acids. Then drugs that lower urinary pH will promote the excretion of bases. So the mechanism underlying these effects is called ion trapping. The drug employed most frequently to alter urinary pH is sodium bicarbonate. So sodium bicarbonate is administered IV and renders the urine more alkaline, which decreases the passive reabsorption of acids like aspirin, phenobarbital, and thereby accelerates their excretion. So because of the buffer systems present in blood, sodium bicarbonate has a relatively small effect on the pH of blood, while having a large effect on the pH of urine. Then for the non-drug methods of poison removal, so several non-drug procedures such as hemodialysis, hemoperfusion, and exchange transfusion can be employed to remove toxicants from the body. So although these procedures are usually of limited value, they can be life-saving in some situations. So non-drug procedures are most effective when first, binding of toxicants to plasma proteins is low, and the second one is blood levels of toxicants are high. For example, when distribution of the toxic agent is restricted to the blood and extracellular fluid. So each of the non-drug methods of poison removal has its benefits and drawbacks. So for example, hemodialysis, so although invasive, can greatly enhance the elimination of poisons. Then the second one is the hemoperfusion. It's a process in which blood is passed over a column of charcoal or absorbent resin. Then, if the affinity of the resin for a particular poison is high, the procedure can strip a toxicant from binding sites on plasma proteins. Then the principal disadvantage of hemoperfusion is a loss of platelets. Then when the binding of a poison to plasma proteins is particularly weak, the exchange transfusion can be an effective method of removal. Let's go further with specific antidotes. So we have heavy metal antagonists. So the heavy metals most frequently responsible for poisoning are iron, lead, mercury, arsenic, gold, and copper. So these metals cause injury by forming complexes with enzymes and other physiologically important molecules. So poisoning may result from environmental exposure, intentional overdose, or therapeutic use of heavy metals. So the drugs given to treat heavy metal poisoning are called chelating agents or chelators. So these agents interact with metals to form chelates, or ring structures in which the metal and the chelating agent form two or more points of attachment. So useful chelating agents have a high affinity for heavy metals and can compete successfully with endogenous molecules for metal binding. So by preventing initial binding of metals to endogenous molecules, chelators can prevent injury. So by stripping metals that have already become bound, chelators can enhance their excretion. Then also the selectivity of a heavy metal antagonist is determined by its affinity for specific metals. So some antagonists are selective for only one metal, and others can form chelates with several metals. So for instance, deferoxamine binds selectively to iron. So in contrast, demercaprol is relatively non-selective. So it will bind tightly with arsenic, mercury, and gold. Then properties desirable in a heavy metal antagonist include: first, high affinity for a toxic metal. Second is low affinity for essential endogenous metals such as magnesium and zinc. Then the ability to reach sites of metal storage. Then high activity at physiologic pH. Then formation of chelates that are less toxic than the free metal. Then the last one, the formation of chelates that are easily excreted. Chelators for iron toxicity. So we have three chelators with a high affinity for iron. So these are deferoxamine, deferoxyrox, and deferriprone. So these are used to treat iron overload caused by chronic blood transfusions in patients with infusion-dependent anemias. Then only one of the drugs, which is the deferoxamine, is also indicated for acute iron poisoning. So first, let's discuss the deferoxamine actions and uses. Deferoxamine or Desferal has a high affinity for ferric iron, so the drug chelates free iron and can also strip iron bound to ferritin and hemosiderin. Next is pharmacokinetics, poorly absorbed from the GI tract and hence requires parenteral administration. So the chelate formed between the deferoxamine and iron is excreted primarily in the urine. Next is the adverse effects. So common reactions include fever, headache, cough, pharyngolaryngeal pain, nasopharyngitis, and bronchitis. So pain may occur at the site of injection. Then rapid IV infusion may cause hypotension, tachycardia, erythema, and urticaria. Next is the contraindications. Because deferoxamine is excreted by the kidneys, the drug should not be given to patients with renal insufficiency or not recommended for pregnant women. Next is the preparations, dosage, and administration. So deferoxamine is applied as a powder to be reconstituted for injection. So the drug can be administered by IM injection and by IV or subcutaneous infusion. So intramuscular injection is preferred, and intravenous infusion is usually reserved for patients in shock. Then the dosage for IM or IV administration is the same. So for the treatment of acute iron poisoning, the initial dose for adults and children is 1 gram. So this is followed for an 8 hours later with 0.5 gram doses. So for IV administration, the maximum rate of infusion is 15 milligrams per kilogram per hour. Next is the Deferoxerox. Actions and uses. The drug is indicated for oral therapy of iron overload resulting from chronic blood transfusions in patients with beta thalassemia or sickle cell anemia, myelodysplastic syndrome, and other infusion-dependent anemias. Pharmacokinetics. So plasma levels peak 1.4 to 4 hours after oral dosing. Then in the blood, Deferoxerox is highly bound to albumin. Then the drug undergoes hepatic metabolism followed by excretion in the bile. Then adverse effects or reactions. So the most common effects are fever, headache, cough, nasopharyngitis, and GI reactions including abdominal pain, nausea, vomiting, and diarrhea. So the most serious adverse effects are renal impairment or renal failure, liver dysfunction or liver failure, and GI hemorrhage. Then for the drug interactions, cholestyramine used to reduce blood cholesterol and aluminum-containing antacids used for peptic ulcers can decrease the absorption of Deferoxerox and can thereby reduce its beneficial effects. Then for the preparations, dosage, and administration, so Deferoxerox is supplied in tablets such as 125 to 50 and 500 milligrams that must be dispersed in fluid. So the tablets should not be swallowed whole. So for doses of less than 1 gram, disperse the tablets in 3.5 ounces of fluid. So for doses greater than 1 gram, disperse in 7 ounces. Then dosing is done once a day on an empty stomach, such as at least 30 minutes before eating at the same time each day. Then the starting dosage is 10 to 20 milligrams per kilogram per day. Then dosage can be adjusted every 3 to 6 months based on serum ferritin levels, but must not exceed 40 milligrams per kilograms per day. Deferoprone. Actions and uses. Indicated for oral therapy of iron overload caused by chronic blood transfusions, but only in patients with thalassemia, or safety and efficacy in patients with other chronic anemias have not been established, and only after treatment with other iron chelators has failed. So, Deferoprone is not used for acute iron poisoning. Its adverse effects. So the most common adverse effects are chromaturia, nausea, abdominal pain, vomiting, arthralgia, and liver toxicity. So the most serious adverse effect is agranulocytosis or neutropenia, which possesses a risk of serious infections and death. Preparations and dosage and administration. So Deferoprone is supplied in 500 milligrams per tablet. So the recommended initial dose is 25 milligrams per kilogram 3 times a day. So the maximum dose is 33 milligrams per kilogram 3 times a day. So absorption can be reduced by mineral supplements and antacids that contain polyvalent cations such as aluminum, iron, zinc. So accordingly, Deferoprone should not be dosed within 4 hours of these substances. Next is the Demercaprol. So actions and uses. So binds with arsenic, gold, mercury, and lead. The resulting chelates are excreted in the urine. So the drug is used as the sole chelator to rid the body of arsenic, mercury, or gold. In addition, the Demercaprol can be combined with edetate calcium disodium or calcium enta to treat poisoning with lead. Pharmacokinetics. Administration is by deep IM injection or intramuscular injection. So the Demercaprol cannot be used orally. So the drug has a short plasma half-life, so with complete elimination occurring in approximately 4 hours. Adverse effects. So at recommended doses, the Demercaprol is generally well tolerated. So tachycardia and elevation of blood pressure occur frequently. Then blood pressure returns to baseline within hours. Pain and sterile abscesses may occur at sites of injection. Then fever is common in children. Then chelates formed with demercaprol are unstable at acidic pH. Hence, if the urine is acidic, heavy metals may dissociate from demercaprol, resulting in renal toxicity. Then preparations, dosage, and administration. So, demercaprol is supplied in ampoules containing 300 milligrams of the drug in 3 ml of peanut oil. So, the preparation is administered by deep intramuscular injection. So, for mild poisoning with gold or arsenic, doses of 2.5 mg per kilogram are administered according to the following schedule. So, 4 times daily on days 1 and 2, then twice daily on day 3, and once daily on day 4, then through 13. So, for acute poisoning with mercury, so the initial dose is 5 mg per kilogram. So, subsequent doses of 2.5 mg per kilogram are administered 1 or 2 times a day or daily for 10 days. Then, for acute poisoning with lead, the mercaprol is combined with calcium edtas. And then for the initial dose, give the mercaprol alone with 4 mg per kilogram. Next is the edetate calcium disodium or calcium edta. Actions and uses. So calcium edta or calcium disodium mercenate is used primarily for lead poisoning. So the drug combines with lead to form a stable chelate that is excreted in the urine. The pharmacokinetics. So calcium edta may be administered through IV or IM. Then the drug is poorly absorbed from the GI tract and hence is not given orally. So elimination is by glomerular filtration. Because calcium edta is excreted by the kidneys, so the drug should be employed only if urine flow is adequate. So if the urine flow is insufficient, flow should be restored with IV fluids prior to giving the chelator. Then adverse effects. So the principal toxicity of calcium edta is renal tubular necrosis. So signs include hematuria and proteinuria. So daily urinalysis should be performed to monitor for these effects. So if renal toxicity develops, the drug should be discontinued immediately. Then for the preparations, dosage, and administration, so calcium edta is supplied in 5 ml ampoules containing 1000 mg of drug. So administration may be through IV or IM. So the IM route is preferred for patients with cerebral edema. So for IV use, the contents of 1 ampule are diluted in 250 to 500 ml of 5% dextrose solution or normal saline. Then infusion should be done slowly over 8 to 12 hours. Then the adult dosage is 1 gram daily for 5 days. Then after a 2-day hiatus or a second course may be given if needed. Then the dosage for children is 1 gram daily administered IV or IM for 5 days. So after a pause of 2 to 4 days, a second course is given. Next is the penicillamine. So actions, penicillamine or coprimine is a breakdown product of penicillin. So commercial preparations are made synthetically. So penicillamine forms water-soluble chelates with copper, iron, lead, arsenic, gold, and mercury. So these complexes are excreted in the urine. Therapeutical uses. So the principal indication is Wilson's disease, so a disorder of copper metabolism. So affected individuals are deficient in ceruloplasmin, so a plasma protein that serves as a copper carrier. So symptoms result from deposition of copper in the liver, brain, kidneys, eyes, and other organs. So penicillamine relieves symptoms by promoting copper excretion. Pharmacokinetics, penicillamine is well absorbed following oral administration. So food greatly reduces the extent of absorption. So once absorbed, penicillamine is rapidly excreted in the urine. Then its adverse effects. So with prolonged use, penicillamine can cause varied and serious toxicities. So deaths have occurred also. Then the drug should be employed only with close medical supervision. Then possible cutaneous reactions include urticaria, maculopapular and morbilliform rash, pemphigoid lesions, and pruritus. Bone marrow suppression can result in leukopenia, agranulocytosis, and aplastic anemia. So all of which can be fatal. Then contraindications. So penicillamine is contraindicated for patients who have experienced agranulocytosis or aplastic anemia when receiving penicillamine in the past. So the drug is also contraindicated for patients with rheumatoid arthritis who are pregnant or have renal insufficiency. Then preparations, dosage, and administration. So penicillamine is supplied in 200 milligrams capsules. So for Wilson's disease, the usual dosage is 750 to 1,500 milligrams daily in divided doses. So doses should be administered 1 hour before meals and at bedtime. So dosage is adjusted on the basis of untoward effects and urinary copper content. So treatment is a long term. Next is Soximer. Actions and uses. So Soximer binds avidly with lead, mercury, and arsenic. So binding is less avid with copper and zinc. Binding to iron, calcium, and magnesium is minimal. Therefore, the Soximer presents no risk of depleting these essential minerals. And Soximer is our most effective drug for lowering blood levels of lead in children. Pharmacokinetics. Soximer is rapidly but variably absorbed following oral administration. So the drug undergoes extensive metabolism. So metabolites and parent drug are eliminated slowly in the urine. Adverse effects appear to be mild. About 10% of patients experience GI reactions such as nausea, diarrhea, and cramps. Other moderate reactions include nasal congestion, muscle pain, and rash. Soximer has caused temporary elevations in serum transaminases, indicating liver injury. So accordingly, serum transaminases should be measured before treatment and weekly thereafter. Preparations, dosage, and administration. So Soximer is supplied in 100 milligram capsules for oral use. So for children over 1 year old, treatment consists of 10 body surface area or 350 body surface area every 8 hours for 5 days. And then every 12 hours for 14 more days. So if needed, the entire course can be repeated after a minimum hiatus of 2 weeks. Next is fomepizole, so actions and uses. So used to treat poisoning by ethylene glycol, so the principal component of antifreeze. So following ingestion, ethylene glycol undergoes gradual enzymatic conversion into glycolic acid. So a toxic acidic metabolite. The result is profound metabolic acidosis, which leads to hyperventilation, coma, seizures, hypertension, pulmonary infiltrates, and renal failure. In the absence of treatment, a lethal dose, which is 100 ml or more, will cause death by multi-organ failure in 24 to 36 hours. Then, pharmacokinetics. After IV infusion, fomepizole distributes rapidly throughout total body water. So a plasma level of 8.2 to 24.6 milligram per liter is sufficient to inhibit alcohol dehydrogenase. So fomepizole undergoes hepatic metabolism followed by excretion in the urine. So the drug induces hepatic cytochrome or P450 enzymes and can thereby accelerate its own metabolism. Then adverse effects. So fomepizole is well tolerated. So the only common adverse effects are headache, nausea, and dizziness. All other adverse effects include bradycardia. Seizures are uncommon. Then preparations, dosage, and administration. So available as a concentrated solution, 1 gram per ml in 1.5 ml vials. So the required dose should be withdrawn from the vial and diluted in at least 100 ml of 0.9% sterile saline or 5% dextrose. So treatment consists of a loading dose such as 15 body surface area followed by 4 smaller doses or 10 body surface area given every 12 hours, then followed by doses of 15 body surface area given every 12 hours until ethylene glycol levels drop below 20 milligram per dilute. So all doses are infused every over 30 minutes. So if the patient is undergoing hemodialysis, fomepizole must be given every 4 hours or rather than every 12 hours. Then poison control centers. So the American Association of Poison Control Centers or AAPCC defines a poison control center as an organization that serves a designated geographic region and provides the following services such as poison information, telephone management advice, and consultation about toxic exposures. Then also hazard surveillance to achieve hazard elimination. And also professional and public education in poisoning, prevention, diagnosis, and treatment. So poison control centers certified by the AAPCC are accessible 24 hours a day. So have a specially trained full-time staff, usually nurses, pharmacists, or both, and are directed by a board-certified physician, toxicologist, and are associated with a medical center that has laboratory facilities and personnel needed for the diagnosis and management of poisoning. In 2002, the AAPCC established a national poison hotline, and that is 1-800-222-1222. Dialing this number from any place in the United States will connect you with the local poison control center. So this is like dialing 911 from any place in the country to contact local emergency service providers. So now let's wrap up our topic or our discussion. So the key point is management of poisoning has 5 basic components such as supportive care, poison identification, prevention of further absorption, promotion of poison removal, and use of specific antidotes. Then put in mind that the preferred method for reducing absorption of ingested poisons is absorption onto activated charcoal, so which should be given no later than 1 hour after poison ingestion. Then also take note that the removal of absorbed poison can be accelerated by using drugs to enhance renal excretion and by non-drug methods such as hemodialysis and exchange transfusion. Then always remember that for most poisons, there is no specific antidote. Then heavy metal poisoning can be treated with chelating agents. Then also, poison control centers offer immediate expert assistance over the phone. Then dialing 1-800-222-1222 from any place in the United States will connect you with the nearest poison control center. And that would be all for this video. Thank you for listening and watching all throughout.